Welcome, everyone. My name is Madeline No, and I'm with NetHope, and we want to welcome you to another NetHope Solutions Center webinar. Today, our topic is Partnerships for Health Data Exchange. And today, we're welcoming presenters from Dimagi, JSI, John Snow Inc., Medic, and the University of Oslo DHIS2 project. Before we get started today, I'd like to go over a few housekeeping guidelines for today's session. We would like to have you keep this an interactive session. Please put your questions and comments in the chat window for our Q&A discussion later in the hour. Also, we will follow up with all of you via email with a link to the recording for this session, as well as any collateral or other information that's been provided during the session. And toward the end of our hour, we would like your feedback. It's very important to us. Please take a minute or two to complete our webinar satisfaction poll toward the end of the hour today. And with that, I will hand it off to Sonia Rutzel from Catholic Relief Services.
Thank you very much, Madeline, and thank you very much, NetHope, for hosting this with us. So today we have various speakers sharing firsthand insights on innovative approaches to partnerships for health data exchange. We'll have 3 different case studies, followed by a Q&A and an interactive discussion amongst the panel. And without further ado, I'd like to introduce you to our fantastic panel. We have Hippolyte Tilahun. He's the project director of Ethiopia Data Use Partnership International at John Snow, and sharing the country study of the Ethiopia Data Use Partnership project. Helen Olsen, the Senior Research Program Manager at Medic, and Jordan Lerner, the Senior Project Manager at Dimagi, and they're both sharing a case study on partnerships for COVID applications for frontline health workers. And Breno Horst, he's the LMIS technical lead in the DHIS2 project at the University of Oslo. And he will share a case study and insights on exchange of health data between health and logistic data management systems. So you can see we have quite a diverse group of topics, and we'll start with our first case study. And during this, you're very welcome to put your questions in the chat. And I also like to mention that we will share those presentation slides with you afterwards, so you don't need to take any notes. So that brings us to our first case study, and I'd like to hand over to Hippolyte Tilahun in Ethiopia.
Thank you very much. Thank you for the opportunity to give this very brief presentation. Can you please display the slides? Okay. So I am going to give a very brief talk about Ethiopia's information revolution. As per the introduction, I work for the Ethiopia Data Use Partnership, DUP. The DUP is the Secretariat of the Ministry of Health in Ethiopia, to support the work on the information revolution. We are funded by the Bill and Melinda Gates Foundation and also the Doris Duke Charitable Foundation. So what I'm going to present is Ethiopia's case study, and which is, I think, an excellent job done by government with the support of stakeholders and partners. Next slide, please. So to just give you a very brief highlight about Ethiopia's information revolution, Ethiopia took information systems and investments on information systems as a key priority 5 years ago, when the first health sector transformation plan was launched. Ethiopia follows a 5 years planning cycle, and that 5 years health sector transformation plan just ended, and we have now a new 5 years health sector transformation plan too. So during the first health sector transformation plan period from 2015 to 2020, information revolution was a top prior agenda for the government. And in brief, our information revolution has 3 main priorities. As you can see from the slide, at the bottom is effective and appropriate health information system governance. So that's one important pillar of the information revolution work. Second is the data use culture creation. So Ethiopia took a commitment to make data use a culture at all levels of the healthcare system. So by generating good quality data and by enhancing and improving its use at all levels of the healthcare system, uh, we are aspiring to reach at an optimal level on informed data, informed decision making. And one of the other priorities is the digitization of priority health information systems, all of this leading to improved health outcomes. Next slide, please. So the core, I think when we talk about partnerships for health data exchange, the core is the architecture, the e-health architecture of Ethiopia, and I'll highlight a few points on our architecture. Next slide, please. So this is Ethiopia's e-health architecture. It was developed sometime around 2018. So the architecture is serving as our blueprint in terms of mapping the different data sources, systems that are in place, the kind of interoperability service that we want to put in place, the different kinds of point of service health information systems that we have in country. So as you can see here, we have identified the shared services, the different kinds of shared services. Some are fully developed, some are under development, some are yet to be developed. We have identified also institution-based health information systems and also the different data sources as you can see it on the slide, including our EHMI's, DHIS2 system, the regulatory information system, and the different institution-based HIs and data sources are also mapped in the architecture. We have also mapped the population-based HIs and the different data sources that we have in the country. And then the most important part of it is the analytics and the business intelligence of it, by which we have a plan of setting up a data warehouse that pulls data from the different sources and also building a data analytics platform on top of it for visualization of data and to facilitate the decision-making process. And not to forget, I think there is always a need to interact with external systems that have relevant information that fits into the health system, and also the health system giving data to the different kinds of systems that are owned by the different sectors. Next slide, please. So in terms of, I think the architecture was designed somewhere around 2018, 2019. So I would like to highlight where we are in terms of our journey as a country. This is a beautiful health extension worker in Ethiopia using an electronic community health information system while providing vaccination services in the rural areas. Next slide, please. So when you look into our journey into 2018, 2019, we have defined our terminology services. The architecture and the roadmap is now well developed. We did an inventory of applications, and we have a comprehensive system that maps the different applications in the country. In 2019, 2020, we developed interoperability software, and also we tested data exchange among the few systems that we have. And based on the architecture also, we applied that into the COVID-19 digitization work, by which we implemented a system that helped us to do a data exchange between the lab information system and the DHIS2 system that we have in place. The next phase is going to be our operationalization phase, by which we will continue to support maintenance of the system, enhance local capacity, and also work on more interoperability solutions in the country. And moving to the future, which is going to focus more on support and maturing phase, we will regularly evaluate the architecture, introduce updates and changes, and also we will implement evaluation matrix. So we regularly evaluate and adapt and customize the architecture for the country. Next slide, please. So I'm going to finish my presentation by highlighting a few of the lessons from Ethiopia as it can apply to other countries. This is a picture taken when we inaugurated the first digital health innovation and learning center in the country, where the architecture, the data exchange work, and all the partnerships that we have in country is going to be led from this center, which is, I think, a big move in the country. Next slide, please. So what are our lessons to share in terms of data use partnerships? I think partnerships, data exchange will be effective if there is a very good government commitment and also a leadership from the government. Without that, I think there is not much that we can do. So that's a very good lesson from Ethiopia. Second is, I think we need to define the visions and the priorities of the country. So in Ethiopia, using the health sector transformation plan, the architecture, the different strategic documents, the vision is outlined very well and the priorities are highlighted. So partners can really follow that vision and priority. Having a standard in place is another experience from Ethiopia. If we have standards and if all the systems are following that standard, then data exchange will be enabled and will be facilitated. Setting up partnership platforms and placing governance protocols is another important lesson from our experience. There are different kinds of partnership platforms that are enabling that discussion. Regularly reviewing progress and taking corrective actions, changes is another lesson from our country. And the other is following a human-centered approach when we develop the systems. I think that's something that can enable the usability of the data. And a deliberate investment in terms of addressing infrastructure challenges. And last but not least is integrating the health information system with digitization is, I think, very important. The two has to go hand in hand and collaboratively, and the Ethiopia is a good model in that regard. Over, and thank you so much.
Thank you very much, Hibret, for your great overview of the Ethiopia Data Use Partnership and for kicking us off. Our next case study is by Helen Olson at Medic and Jordan Lerner at Dimagi, sharing their partnership on for COVID response for frontline health workers. So Helen and Jordan, over to you. Thank you.
Thanks, Sonia, and thanks, Brett. That was wonderful to hear, and we're really fascinating. We're going to talk about a different type of partnership, but I do think there are many common threads that we'll touch upon. So thank you all for having us today, and we're excited to be here. If you could go to the next slide. My name is Jordan Lerner. I'm a senior project manager at Dimagi. I've been leading our international COVID-19 response work for the past year. I'm excited to co-present today with Helen Olson, Medic Senior Program Manager and one of my closest collaborators for the past year. For those not familiar, Helen and I represent two separate organizations that do somewhat similar things. Both of our orgs develop an open source platform to equip frontline workers with mobile apps, and we have services teams to help frontline programs deploy our platforms for that purpose. For those of you who know us better by our platform names, Dimagi supports the ComCare platform, and Medic supports the Community Health Toolkit. Medic and Dimagi have essentially been in friendly competition for the last decade. And while we've talked a lot about how we could work together, it wasn't until last year that we really had the chance to do so. When COVID-19 hit, there was an urgent need for digital technology to support efforts to mitigate and suppress the pandemic. And it became clear quickly that you really can't do contact tracing or testing or event-based surveillance at scale without some kind of digital platform. We were fortunate to receive funding from the Rockefeller Foundation that allowed us to roll out a wide range of COVID-19 response apps on both of our platforms. The funding allowed us to, moreover, do a lot of collaborative work, co-designing modules, sharing lessons and information to improve our applications, and building shared dashboards to demonstrate how data could be visualized across platforms. And we ended up building a wide range of pandemic response tools. Apps for frontline workers to facilitate contact tracing, event-based surveillance, port of entry screening, facility readiness. We co-designed a module for home-based care, and even more. So if you can go to the next slide, you'll see that there was a lot of uptake on these platforms. Over 100 frontline programs across 35 countries have used these applications. There have been over 40,000 users of these apps, where a user is doing like contact tracing, or they're a community health worker delivering home-based care for COVID. And there have been 26 million forms submitted. Generally, we consider a form to be an interaction with the system or an action on behalf of a healthcare worker. And we're proud in that the graph shows how much this effort has increased in its impact over time. Helen?
Thank you so much, Jordan. And if we could go to the next slide. It's been really exciting to see our partnership flourish. And in fact, it's gained momentum faster than I think either of us expected. And our organizations have a lot in common, but there's also differences in culture and working style that were really energized during this pandemic moment. And the partnership has been great fun. In the past year, I think I've brainstormed with Jordan and members of the Dimagi team more than most of my coworkers at Medic. And it's been wonderful to have that thought partnership as both of our organizations grappled with how to rapidly approach both adapting existing applications and developing a joint conceptual model to enable rapid uptake of digital tools focused on COVID-specific use cases. And as we look ahead to the next phase of our partnership together, we're considering the ways in which our collaboration has influenced our coordination and engagement around COVID, and the role that digital tools play more broadly in supporting frontline health workers in the delivery of essential services and more direct COVID-19 response efforts. As you see in our joint conceptual model, there's a range of critical use cases that really speak to different phases of the pandemic that are enabled across both Medic and Dimagi, ranging from facility readiness and stock management to adaptations to primary healthcare delivery workflows to ensure that continuity of care is maintained during global health emergencies such as COVID-19. And I think critically, our collaboration has illustrated the value of openness and collaboration and coordination within the digital health space, particularly for digital platforms, in ensuring opportunities for both Medic and Dimagi to deliver for partners and build our networks, while simultaneously ensuring alignment in our conceptual approach to the pandemic response. Our shared design work, as well as work on configuring and deploying these jointly imagined COVID-19 workflows and use cases, really enabled the breadth that Jordan has spoke to on the previous slide around the uptake and sustained engagement with either ComCare or the CHT, and enabling those over 26 million unique moments in which care was delivered via one of our two digital platforms. And I think most critically, our collaboration has enabled broader engagement across both Medic and Dimagi in shared data models, joint analytics, and an emphasis on the power of collaboration, not just in the development of digital tools to support frontline healthcare workers during the pandemic, but also the role that data systems and analytics themselves can and should play in making data-driven decisions, both during the pandemic and as we think ahead to broader pandemic preparedness efforts and the joint work that our organizations could do together. We've learned through our collaboration that rather than siloing our efforts, this type of joint approach ensures that care is delivered more effectively and efficiently across countries and partners, while also ensuring a harmonized approach and consistency in that care delivery. Our next phase of work together, which is focused on equitable vaccine delivery, will build on these learnings and help us imagine future opportunities to continue this, I think in some ways, quite radical collaboration And I'm going to turn it over to Jordan to close us out.
Thanks, Helen. And just to share one final learning and note to tie this up, as we look forward to the next phase of this partnership, we want to make sure that the lessons that we learn continue to power us forward. And one that sticks in my mind, and I think is worth sharing today, as it's become abundantly clear, is that one of the components of the success of this partnership thus far has been the time and space that we were afforded through the generous funding from the Rockefeller Foundation to learn how to work together. Partnerships like ours that span across organizations or sectors are really all about trust and the relationship that can be built between organizations, and their success depends on the amount of time and effort that you can put into them. So this joint conceptual framework that you see in front of you now was one of the first efforts that we undertook through this partnership. And I imagine Helen would echo the sentiment that our efficiency there is not what it was today. And I think that's a testament to the time that we were afforded to learn how to work together, to learn that oftentimes in these cross-collaborative partnerships, it's best for one partner to take the lead while the other supports. And it's been an absolute pleasure to learn from and work with the Medic team. So thank you all so much for the opportunity to share this case study with you today. We of course welcome questions, comments, and feedback. Thanks.
Thank you, Jordan, and thank you, Helen, for sharing this case study with us. And yeah, as you said, we're happy to take questions. But before we do, we have one more case study for you from Breno Horst at the University of Oslo, talking about how DHIS2 can be used for integrating digital end-user stock management systems for effective logistics management, which is obviously very, very important right now in the COVID response and the vaccination response. So Breno, over to you.
Okay, thank you very much, and thank you to the fellow panelists as well. Very good, interesting presentations thus far. So I'm the Logistics Management Information System Technical Lead in the DHIS2 project in the University of Oslo. And yes, integrating digital end-user stock management systems for effective logistics management and improved health service delivery. So that's quite a heavy title for my presentation, but I promise it will be easy to understand from here on out. So just to give a quick background that for DHIS2, that it's being widely used for health data capture and analysis at various levels. And I will be focusing then on the logistics management use case, stock management use case within the system. And I'll be presenting to you then some of the vision that we have for the specific LMIS case, and then the allow integration case with another upstream logistics management system. Next slide, please. So this is the quite straightforward problem statement that we had, that inefficient and low quality logistics services contribute to poor quality health service delivery. The quality of the health service delivery being the endpoint, not that we're doing this for the sake of the logistics management itself, but we want to improve the quality of health services. And then the desired future state we try to get to is the improved health service delivery through improved logistics services. Next slide, please. So again, staying on the vision that we have for LMIS within the DHIS2 project, I just want to highlight this proposed integration architecture, where we have then the Ministry of Health there with different levels represented in the center. On the right side with the health information, where you might have DHIS2 being used at different levels to capture, aggregate, analyze, and display data. And on the left side, you have your logistics information, and there specifically we see the role of DHIS2 at the end user level, at the facility level, community health worker level, using the DHIS2 platform, mobile application, or the web app to capture data digitally, and to then share this with an upstream, what we would call an upstream logistics system, which has full logistics management functionality, procurement, warehousing, transport, and distribution, and so on. And then achieving that through multiple ways of connection, either through a direct integration with the use of APIs or through an interoperability layer, which we might encounter, which was presented earlier in the Ethiopia case, where you have multiple systems interconnected. But in either case, we would have a way of connecting then the end user data with an upstream system. And then I'll go into now a practical example of where this has been done in Laos. Next slide, please. Where the Ministry of Health, to address supply chain management challenges, implemented a logistics management information system, in this case M-Supply, at all drug warehouses across central, provincial, and district levels. So this is, again, what we would refer to as the upstream. And then at the end user in facilities not implementing M-Supply, DHIS2 was used to capture data and report at different reporting intervals. This can be changed from daily, weekly, monthly as needed. And you see a sample form there from within the DHIS2 system where you could capture stock data at this end user level and have quite a broad coverage of low-level sites where you provide health services and then also capture stock data, which otherwise would not be available with only the use of the upstream system. Next slide, please. So with capturing both the end user stock data and connecting that with an upstream system, you have health data in DHIS2 with end user stock data, also with your supply chain data, which can be put together and analyzed and provide a higher level analysis. For example, comparing your stock on hand with monthly needed stock, accounting for historical test and case trends, seasonality, and these variations, and comparing stock availability with your forecasting, and then also being able to see how much stock on hand you have for individual items in any specific health center. Next slide. And then another type of analysis would be to have availability of stocks by facilities to enable redistribution if needed. If you have an overstock in a certain facility where a nearby facility might have a stock out, you're able to redistribute and have this visibility at the end user level, at the health facility level. Next slide. Yes, so then some of the lessons learned, I think, and again, being repeated from one of some of the previous cases presented here, it's the clear ownership and defined roles and responsibilities to have this sort of vision for how this integration will happen. Alignment of objectives and coordination among implementing partners and stakeholders is quite important. And then identifying the complementarity between the systems, where you might have DHIS2 and M-Supply in this case, each bringing in a certain set of data, which can be put together to provide analysis. And now back to the development of the DHIS2 platform and specifically LMIS. What we're looking to do going forward is to develop demo integrations with multiple LMIS and ERP vendors to show that we can share this data and have this integration with multiple systems depending on what is available in a country, so that we're not, we show that we're able to integrate with multiple systems. For the LMIS functionalities themselves, we're looking at ledger or transaction-based stock monitoring using our DHIS2 tracker application, which would then give even better visibility and real-time data on stock on hand. And then developing features such as automated temperature monitoring and even an end user product catalog, which again would provide data from an upstream system to an end user level and giving health workers providing health services details on the items that they need. All right, so that's the vision and the case of integration in Lao, and I will hand it back to Sonia.
Thank you very much, Bruno, and thank you very much to all the speakers for your interesting case studies. Just a reminder for all attendees, you can still add some questions in the chat. I know we have already a number of them, and we'll get started on those. My first question is for Hilbert, is specifically around your the platform you have shared. The questions here is, first of all, the terminology register, is it based on a specific platform, and who's responsible maintaining it? Is it a government or is it a partner?
Yeah, so I think one of the lessons that I already echoed in my presentation is like government ownership and leadership in Ethiopia. So there is no system that's not owned and led by the government. So Ethiopia is very unique in that regard. So the NHDD being a national terminology service, it's primarily owned by the government. There is a support coming from partners, including the data use partnership. We provide technical assistance and any need-based support to the ministry under the leadership of the ministry. So the system is like, it has a web application which is hosted on OCL. There is a mobile app that can be downloaded by health workers for a use. And there is also a paper-based pocket guide of the terminology service that's distributed all over the country. We regularly do assessments. We collect feedback from the health workers, from the users, and we update the terminology services as needed. And that's serving as our primary source of information for a national classification of diseases in the country. Over.
Thank you. I think that already answers also partly the other question that was specifically around if there are clear standards in relation to sharing the data with other partners like NGOs or academia. So you already mentioned the health frontline workers. Are there any other guidance on other partners?
So in terms of data sharing, I think that's a very good question. As I said, the way we are implementing the architecture is there is this say like how do you eat an elephant? So if you do it by piece, then that's possible. So the architecture being a very broad and comprehensive framework, Ethiopia is trying to address the issues case by case. Developing the system, the data exchange, and so on is being built gradually. So in terms of data access and sharing, there are activities that are on pipeline. Like one is there is a national data management center hosted by one of the agencies in Ethiopia. It's called under one of the agencies, which has been up and running and functional, mostly for survey-related data. From the ministry side, there is a process and an activities going on to establish a national data warehouse where you can easily access different data sets, and you can make that available and accessible as needed. There is a way, an investment going also in terms of setting up a public portal, so we can make selected data sets accessible for any public that would be interested to have. And currently, we are also working on developing a national data sharing directive. So this is a kind of a nationally agreed data sharing protocol, where government will be accountable to share data, and also partners are also responsible and accountable to share data for anyone interested or has interest in accessing the data. So while I think these efforts are going on, the way that government is managing data access right now is in a case-by-case way. So if any academia or non-governmental organization wants to get data from the ministry, then they have to submit a written request to the ministry. So there is a process that the ministry reviews the request and will provide that set of data to the specific organization or individual who made the request. Over.
Thank you very much. Staying with the theme of data privacy, I also have a question for Helen and Jordan. First of all, if you either want to generically mention a few words around your data privacy related concerns, but then also there is a specific question if you are seeing a trend to incorporate synthetic data for modeling.
Thank you so much for this question. I can speak to data privacy at a high level before speaking a bit more explicitly to some of the exploratory work that I believe both Medic and Dimagi are engaging in the use of synthetic data. And I'll turn it over to Jordan to add additional context. Broadly, in the development and engagement with our collaborative work around COVID-19, we wanted to use as much as possible templatized or synthetic data sets in our adaptation and creation of some of our joint workflows and data models, in part because we were building these reference architectures and applications before they were deployed. More broadly within our collaboration, I know that Medic has a responsible data policy that we follow in all collaborations and really ensure a high level of compliance with any in-country guidelines, either GDPR or other style of legal protections around data rights and data hosting. We also, in a lot of our research and data science work, are increasingly moving towards implementing differential privacy protocols and exploring the use of synthetic data for more of our high-level data science work, including the generation of synthetic data sets that are reflective of data generated at the point of care by digital tools used for community health, and thinking through how those synthetic data sets themselves can be used for modeling, A/B testing, and other areas of work, really towards a broader program of work focused on responsible data governance and a more ethical way of engaging in AI, particularly in the context of community health. Jordan, curious if you have anything to add, and welcome additional questions on this topic. It's something that we're thinking about quite critically right now.
Thanks, Helen. And another thing I've learned throughout this partnership is that, yeah, Medic and Dimagi are doing a lot of similar work in this space, and that whenever I hear about it from Helen and others from the Medic team, it gets me excited all over again. I'd echo a lot of the data privacy regulations that Helen shared. Dimagi follows similar standards when it comes to protecting personal data. I think not a ton to add. One of the interesting components I'd note is that throughout the partnership with Medic over the past year, we spent a lot of time understanding and theorizing how platforms like Community Health Toolkit and ComCare could work together to create shared data sets and create shared analytics and put the data from both platforms into a single dashboard. And as we described and as we theorized and eventually actually developed that work, it was entirely with the use of synthetic data sets used by created by our research and learning teams. So certainly there's value, as Helen mentioned, in ethical AI, but additionally, as we still continue to discuss and theorize how we can be sharing across platforms, there's, I believe, value in these synthetic data sets and in just actually putting the theory to practice before we actually bring it to the implementation level. Over.
Thank you, Jordan. Breno, do you have anything to add around either data privacy related concerns or synthetic data sets for modeling?
Not so much, especially for the former, since we're dealing with stock data. So it's not a particular issue as we're not collecting person-specific data. So nothing to add on those.
And I have another question for you. Maybe Breno, for you first, and then Hilbert, I also love to hear your thoughts on this. So this question is from Jake, and it is about the important step he's seen in the evolution of AI in organization and enterprises as the creation of a cross-functional center of excellence. And so he's interested to hear if this is on the roadmap or a useful approach for Breno, or then later Hilbert, in the work you're doing. And so he also says that he has seen great efforts on data collection and analysis, but thinks there could be more done towards predictive or even less prescriptive analytic models?
Sure, this is actually very exciting field of work, and definitely something that we discuss and we have in our roadmap. But to be honest, it's not in the immediate future, as the focus or the priority is first getting the data into the system, getting this data from the last mile of service delivery. We can refer to as the first data mile, and getting that digitally recorded and moving away from paper-based, changing behavior and gaining acceptance, and being able to implement a fully digital system to first get that data is, I think, the first step, and still quite a challenge. Eventually, to move towards being able to use AI and this type of technology is also something that we would see in collaboration with, and I guess related to another question that came up from another panelist, to the what again I've been referring to as the upstream LMIS, so the system which would be doing calculations and managing the supply chain, so not directly native in the DHIS2 platform. So in a sense it is, and it's more of a long-term ambition. However, in the immediate future, it's really getting the data digitally from the first step is in the immediate future. Over to Hibrit.
Herbert, is artificial intelligence on your sort of radar for the immediate future, or you're in a similar situation as Breno?
Yeah, that's a great question. I think it's definitely part of our architecture. In the presentation that I made, there is a component that says business intelligence and analytics. So currently, our focus has been to look into coverage data, like how many are vaccinated for, let's say, measles, and so on, kind of thing, very descriptive and coverage kind of analysis. But in the future, our way forward is to apply AI and other data modeling techniques to be able to do some predictions and also more advanced analytics, and also some level of triangulation of data from different sources to give more meaningful analysis for decision making. As you know, there is a limited local capacity in data modeling, AI, and so on. There are local universities that already started postgraduate studies on data science. Particularly one of the universities, Gondar University, they are taking this as part of their center of excellence. So we're at the country, we're collaborating with the university. They have also a DHIS2 academy in that institutes. So we're trying to collaborate locally, but we're also open to external support. Once we know what we want to get out of that, we will also look from other countries and global experience on how we can apply these techniques in the future. Over.
Thank you. That leads me to a bit more of a broader question before I have a few more specific ones on DHIS2. My broader question is really, so we have now seen different partnership models. How can we improve the collaboration and the data exchange across sectors or across borders? Are there any volunteers to answer this question, even if it's from a sector perspective or from an individual or organizational perspective? Any sort of points of action?
If I can come with a comment from the DHIS2 side. And this is somewhat of a general comment in line with, I think, common knowledge when it comes to designing these types of systems, but it's to have the user at the center and understanding what the need and the value added is. That sometimes interoperability for its own sake or data exchange for its own sake, vendor-driven partnerships can stray slightly from that perspective of having the user and the value added for the overall objective that we're trying to attain. So that's one discussion that often comes back, is that it's not data exchange or interoperability or integration for the sake of itself, but that we keep in mind the end user.
Thank you. Yeah, that was already, I think, the big takeaway from the case studies from Hubert and Helen, Jordan, and I think yourself, and the human-centered, user-centered design. So, Helen or Jordan, do you have any other comments on what you think the sector can do, even if you want to look away from private sector, you want to look at maybe implementing partners, other partners?
That's a really great question, and I think I would echo the comments around an emphasis on centering the user and centering the user's experience in how particular integrations or platforms are developed. Technologies and digital tools are not independent and should be independent of the context in which they're used. And I think our ultimate goal is to build tools that are reflective of broader care delivery and supporting health systems. And in our collaborative work together, we really had to take a broad perspective on what potential use cases and health system capacity could be in the range of settings that might be adopting either a CommCare or a CHT application in the context of COVID-19. But I think there's also a health system strengthening orientation where the addition of digital and the use of data to enable data-driven decision-making really should be predicated on the notion that digital is supporting that care delivery and supporting that health system, whether it's at the scale of the community, whether it's via integrations to include facility data as well as community data collected at the point of care, whether it's including an integration to enable stock monitoring and supply chain work. And I think for us, it's that frame of what enables the delivery of care and how can a digital tool be created and implemented in a way that is reflective both of users' needs, but also for where the health system wants to grow and evolve to. Jordan, curious if you have anything to add. I hope that's reflective of our joint perspective. I believe it is.
Absolutely. I think, Helen, the points that you touched on, and Breno as well. And I think I'd actually want to go back to a point that Breno made previously that I thought was well put, and to think that when we think about integrations, cross-sectoral collaborations, I think starting small and not underestimating the breadth of that transition from paper to digital, and getting that first step right is critical when you think through this larger picture. So in order to improve these collaborations, I think it's important to be first and foremost realistic about what can be achieved, and as Helen said, take a health system centric approach to what you're doing, making sure that these planned integrations have real-time value, and that you aren't putting the cart before the horse, so to say, making sure you build a strong culture around data use. I think as Brett did a really wonderful job of demonstrating how they've done in Ethiopia, and taking the necessary steps to build towards larger cross-sectoral, cross-border integrations and collaboration. Over.
Thank you. I guess that also really leads us to the question of partnering or teaming up for digital capacity building or data literacy, which is obviously, awareness is key, but then the next step is really looking at that we have the right capacities in our organizations, in our partner organizations and communities. Maybe, Hubert, if I can start with you, is there any plans or any advice you like to give, particularly when we're looking at it from a partnership angle, not just what your own organization is doing around the capacity building and the data literacy?
Yeah, thank you. That's a good question. I think that's very relevant for countries like Ethiopia. This is like a growing area of engagement. Technology changes every time. You know, it's always necessary to catch up with that. I think from the Ethiopia experience, the way we're trying to handle local capacities by working with local academic institutions or the local universities. We are creating center of excellence in the different universities depending on their capacity and their interest. For example, on electronic community health information system, we're working with Jimma University as our center of excellence. As I said, data science, data analytics, we are working with Gondar University. When it comes to data exchange and the architecture related work, we are as a country working with one of the universities in the north, Makale University, as the center of excellence. When it comes to development, customization, and so on, we're working with the Addis Ababa University. As I said, the Digital Health Innovation and Learning Center will serve as a coordinating body across all these sectors. So it's always, I think, necessary to remember, like, this is going to be a team-based work. There is not going to be any one individual that's going to come up with all the skill sets that we need. So the more we have the right mix of, the different backgrounds that we need, then the better our work will be. So the way we are approaching it is like, who will bring what into this work? And if there is a missing skill, how do we nurture that skill in country? And how do we make it that sustainable? How do we integrate that into the pre-service education system? How do we integrate that with the research activities that are going in the country? For example, implementation research is also one other priority in Ethiopia. And currently there are about 11 implementation research that are going on health information systems, including data exchange. This is the implementation research activities are joint research work by teaming up among the ministry, the regional health bureaus, the local universities, and partners are jointly identifying priority research agenda. And then we are providing resources from the DDCF grant to the universities to do implementation research on those identified areas. And then that is going to feed into the program implementation. And one of this implementation research is on data exchange related work. So I think the more we deliberately engage in it, the better it is. Thank you.
Thank you very much, Hibret. I know, Breno, University of Oslo, in particular DHIS2 project, is doing a lot of capacity building. And do you have anything specifically to bring to the table around partnerships, collaborations, or even opportunities for other organizations to partner with the DHIS2 project?
Certainly there would be in other areas. I can only answer now for the LMIS aspect of it. And in that sense, what we're looking at is other platforms that similar to mSupply that provide this full-scale logistics management capacity that is used by different organizations and countries at Ministry of Health level. And we're partnering with them and developing then these demo integrations, and then providing the possibility to for any country to integrate at that level. When it comes to actually the implementation and capacity building, it would be what we're looking at really is this, in a sense, behavior change and acceptance and trust in a digital system, in a mobile solution, and not the paper-based, which is often the common usage at a health facility level by a health worker, that they get to a point where you have the trust in the mobile solution that we provide, and we move away from paper. That's the, but we understand that that takes time, and that's something that is a process that we need to get to. Over.
Thank you. And maybe because I saw a couple of questions in the chat, just to clarify a little bit more the difference between mSupply, how is it different from DHIS2, and why you have chosen DHIS2 rather than mSupply for entering stock data at the lowest level. If you could maybe sort of clarify that a little bit again.
Sure. So I used the term LMIS in a very generic sense. mSupply is a platform providing procurement, warehousing, transport, and let's say full-scale logistics management features. DHIS2 is the health information system, and I only refer to then LMIS there for the very specific stock monitoring and a few other, let's say, basic features that we've built into the DHIS2 system. So the integration is between DHIS2 and mSupply. And then to the second question, DHIS2 was chosen in this case to be rolled out to these facilities because it was already present. It had been used for multiple years in country. And these, let's say, lower level facilities, they will not have a dedicated pharmacist or a storekeeper or a logistician. It might be a health worker, a nurse entering this data. So using the system which they're already using to record health data, they're familiar with it. It's only a question of an additional window or dialogue to input then stock on hand or stock distributed is the advantage of using the DHIS2 and then simply sending this data to the upstream system. Of course, if there already is some form of data capture, digital data capture, the idea is not to move away from that. It's then to still integrate and share the data into DHIS2 system and to be able to reach this level of analysis and triangulation of logistics and health data. But when there is already the presence and the acceptance, the knowledge at the user level of the DHIS2 mobile system or the web interface, that there's not a need to then introduce a secondary item simply for the digital data capture. So again, the focus is that to maximize the usage of DHIS2 where it's already been in place and in use and is familiar to the users in country.
Thank you very much. Now we have talked about a lot of different partnerships, obviously heard from the government, heard from private sector and academia partners, but I also wanted to mention that partnership sometimes also starts within our own organizations, depending obviously the size of our organizations, but we might also want to look at the collaboration between our technical teams, like an ICT4D team or whatever terminology we want to use, and our monitoring and evaluation teams. And I think that could also be an interesting discussion, given that in our sector, the humanitarian development sector, we're not very consistent. We don't even have the same job titles, so we're clearly not even consistent how we are coordinating within our own organizations. So this might be something we might want to look at a future webinar. I also wanted to share in this chat that this webinar is also based on a previous one we did in June, where we particularly talked about the COVID-19 response at that point and the interoperability and integration of health data. So I will place that in the chat now as well. And that already leaves me to thank all our speakers for sharing your insights and for everybody to attending. And please do fill out our satisfaction poll before you leave. And we're looking forward to see you again next month for a new ICT4D webinar. Thank you so much.
Thank you, Sonia.
Thank you so much. Thank you.
Thank you for coordinating, and thank you everyone for joining.
Thank you, everyone. Thank you to all of our attendees today as well. Thank you to all of our speakers. It was a great session, very, very informative. Please do take a moment before you log off to complete our webinar satisfaction poll, where your feedback is very important. And do look for the email follow-up that will include a link to the recording so you can share that with your colleagues and friends. It will also include any other details or information from the session. And with that, we will wish you to have a great rest of your day. Thank you for attending.
Thank you very much. Bye.